Good evening and welcome to this webinar this evening. I'm Tony Rutherford. I'm a consultant in reproductive medicine and I'm based in Leeds. I've been working in IVF now since 1985, initially starting my IVF journey at the Hammersmith Hospital in London with Professor Lord Winston, and then setting up the IVF unit here in Leeds in 1990. So today we're going to go through an introduction to IVF and some basic infertility investigations. Next slide, Katie. So what are the common causes of infertility? Well, there can be problems for both partners. On the female side, age is an important one. The best decade to have kids is between 20 and 30. But modern life is such that we often delay and we don't start trying for a baby until we're 30. And then natural fertility starts to decline. It becomes more accelerated as you get above the age of 40. And pregnancy is fairly rare once you get above the age of 45. You can have problem in the pelvis. Your fallopian tubes can get blocked if you've had a pelvic infection or you've had some surgery. Endometriosis, a nasty condition where the lining of the womb grows outside the womb, and it's commonly associated with painful periods, can be associated with infertility. It counts for about 6%. Anovulation means you don't ovulate. You've got irregular periods. And one of the most common causes of that in our population is polycystic ovaries. It could be a combination of these factors. On the male side, and male fertility accounts for at least a third of all cases, you could have a low sperm count, or the quality of the sperm might not be good. It might not be moving well, or it could be that the sperm look abnormal. Again, you could have a blocked tube raft infection, or you might have been born without the tube that carries the sperm from the testis to the outside. You might have had a vasectomy, having thought you'd completed your family, met a new partner, and you want to have children again. And in some men, they may be born with the inability to make sperm because the germ cells that actually make the sperm are not present. We find combined problems in about 20 to 30%. And in about 27%, we can't find an obvious reason. It doesn't mean to say there isn't one. It's just not obvious with the available technology that we have now. And that we call unexplained infertility. Next slide, please. So it's really important that we try and work out what the diagnosis is, what the cause of infertility is in you as a couple, because that will help us plan the best treatment for you. So next slide, please. So how do we do that? Well, we do some pre-treatment tests. We do some blood tests, and the blood tests look at a range of things. In the woman, they look at something called AMH, anti-Müllerian hormone, which is a hormone which is made by follicles which are actively growing. The follicles are the structures that contain the eggs in the ovary. So the higher the AMH, the more growing follicles, the better your ovarian reserve. We also want to look at some general health tests. For example, blood count, make sure you're not anemic. We're trying to get you pregnant. We want to start the pregnancy in a healthy state. Vitamin D levels. It's amazing that vitamin D, a simple vitamin D, can make such a difference to the outcome of fertility treatments. And in the winter months, when we're not exposed to sunshine, about 84% of us have low vitamin D levels. We can look at your thyroid gland. Thyroid is really, really important for the developing fetus. It can't make it itself before 12 weeks. So we need to make sure that your thyroxine levels are normal. Also, we check for diabetes because, again, high blood sugars can lead to problems and early miscarriage. As well as doing blood tests, we perform a pelvic ultrasound scan. The pelvic ultrasound can look at the womb, the uterus. It can look at how thick the lining is. It can see that the uterus has got a normal shape. It can see whether the fallopian tubes are distended into what we call a hydrosalpinx. It can see abnormalities in the womb, like fibroids, which are benign lumps of muscle that can grow in the womb wall. We can also see whether you've got polyps in the uterine cavity, which again can cause infertility. So doing a pelvic ultrasound is important. The other thing that we can see on the ultrasound is whether you've got any cysts on your ovaries, and we can count the number of follicles that we see. At the beginning of a menstrual cycle, you have a group of developing follicles which have taken about 9 months to get to that stage. And when you're on a period, one of the follicles will go on and be selected to be the follicle that develops that month to release the egg in your natural cycle. And we can count the number of follicles, and that gives us an indication of, again, your ovarian reserve. For a man, it's pretty simple. At the beginning, he just has a sperm test, and that shows whether the count of the sperm is normal, the volume of the sample is normal, whether there's enough sperm moving in a progressive manner, and whether they look normal too. Next slide, please. We like to complete those tests before you have your consultation, because that means the consultation is so much more worthwhile, because we can look at those tests before you're seen in the clinic. We then discuss with you your history. Are there any issues that might point us in a particular direction? Painful periods might signify a pelvic factor, such as problems with your tubes or problem with endometriosis. Heavy periods might suggest you might have fibroids. Absent periods may suggest you're not ovulating. A history of mumps in a man might suggest that there may be a problem with him making sperm. So taking a detailed history, including all the medications that you're taking, it's not relevant whether you think it's a problem. Any medical issue may contribute to fertility. So it's important that we get a full history at the start. We then look at the results. And once we've looked at those results, put them together with your history, we can hopefully reach the right diagnosis. And then we can talk through your treatment options. Now, a lot of the patients that we see in care are funded through the NHS. Many more, unfortunately, don't have NHS funding or have decided to try and skip waiting lists and come privately. But we can talk you through your funding options at that initial consultation. Next slide, please, Katie. So let's talk you through the IVF process. Nobody thinks they're going to have a problem with fertility. Unfortunately, 1 in 6 of us will have a problem. When we come to have the test performed, we don't really want to have IVF. We think it's the last resort. For many, it is the only option. And actually, if IVF is used at the appropriate time and not as a last resort, we get much better results. We know how daunting it is at the start of treatment, but we want to make you feel that you've been seen, heard, and supported at every step of your fertility journey. Next slide, thank you. So what does IVF mean? In vitro fertilization, fertilization in the laboratory. It's a fertility treatment where the egg and sperm meet outside the body. It has been used. The first IVF baby was born in 1978. And there's a film about that now called Joy. If you haven't seen it, it's certainly worth a watch. Things have changed a lot since then. And the success rates with IVF are much more successful nowadays. But it helps many couples to conceive who weren't able to conceive naturally. Over 1.3% of all babies born in the UK are now born through the IVF process. Next slide, please. So let's talk you through this in a bit by bit way. So stage one is we're going to talk about ovarian stimulation, so we can collect a whole batch of eggs together, how we monitor to make sure you're making plenty of eggs, and then I'm talk you through the egg retrieval, the egg collection, and then how you prepare the sperm for the fertilization. Next slide, thank you. So the first thing we do is we need to stimulate your ovaries. Earlier, I mentioned we measured your antral follicle count. And at the beginning of your cycle, when we scan your ovaries, you'll have a number of small follicles. It is these follicles that we're going to try and grow. Naturally, your body only releases enough hormone to stimulate one every month, because women were built to carry one baby at a time. What we do in IVF is if you've got 10 to 12 follicles there, we want to get them all to grow. So we get a whole year's supply of eggs in one go. And that's what makes IVF successful. To do that, we have to give you the natural hormone, follicle stimulating hormone. Unfortunately, it's a protein. And so you can't take it by mouth. You have to give it by an injection. But don't worry, it's a tiny, tiny little needle. And we teach you how to give these injections. And you're going to do it on average from the time you start your treatment for around about 10 to 12 days. You are going to produce lots of the female hormones, such as estrogen. And so your body might get a little bit confused and try and make you ovulate early. So we give you a second modified natural hormone from day 6 of your cycle. And what that does is blocks ovulation. Next slide, please. We monitor your response using vaginal ultrasound. So vaginal ultrasound is used. It's a probe. You can just about see it at the back of this picture here. There you go. There's the probe. And that vaginal probe gets very close to the ovaries, because the ovaries lie right at the top of the vagina. And it means we can measure follicles more accurately. And normally we do a scan. It varies. If you've got a lot of small follicles, and we're quite concerned that you might over-respond and produce too many eggs, we might scan you early on day 7. If you've got an average number of follicles, routinely we'd scan you before on around day 9 to 10. There's no point scanning you before you're really ready for us to make a decision on whether we reduce your dose if you're overstimulating, or you're ready for your egg collection. So most women will need maybe 1 or 2 scans during the course of their stimulation process. Next slide, please. So the egg collection. Again, people get so worried about the egg collection. The egg collection is performed under a sedation anesthetic. It's called conscious sedation. We give 2 drugs, one called midazolam, trade name Hypnoval, and it does what it says on the tin. It hypnotizes you. And the other one is a powerful water-soluble narcotic called fentanyl. And those are administered before we start the procedure. We also give you some local anesthetic into the top of the vagina to numb the skin where we put the needle through. We then put a needle through the top of the vagina into your ovaries, and we drain the fluid in which, at this stage, the egg should be resting. We get eggs out of 8 out of 10 follicles we stick a needle into. The whole process takes around 30 minutes. And then there's a recovery period of between 1.5 to 2 hours before you can go home. So it's a fairly simple, straightforward procedure. There's a very small risk of bleeding at the time of the egg collection, a very small risk of infection, but we're talking about less than 1%. So it's a relatively safe procedure. Next slide, please. The man is told to go and produce his sample. We have bedrooms available for you to produce a sample on site. And then the embryologist, once the man produces his sample, will have a look at it. And if you've got a good normal count, what we'll do is that we'll prepare the sperm, we'll wash it, get rid of the old poorly moving sperm and concentrate the really good sperm before the insemination process. Would you like to move to the next slide, please? So we're going to talk about the fertilization and embryo development. Next slide, please. So once we've got the eggs, they're placed in a special culture medium and they're kept in the incubator and they're inseminated. We normally perform the egg collection about 36 hours after you were given a trigger injection, but we inseminate them about 40 hours after the egg collection. And it used to be called test tube baby treatment because we used to put it into a test tube, but now we put it into a Petri dish. It doesn't sound quite sexy, really, but you put about 20,000 sperm with each egg, and this is this prepared sample. And then we leave them overnight, and we have a look 16 hours later to see whether the eggs have fertilized. Next slide, please. If you have a really low sperm test, or the sperm are not moving very well, we use a process to fertilize the eggs called intracytoplasmic sperm injection. This was developed in 1991 with the first baby born in 1992. Now, this is an example where a single sperm is put into the tube, into a small glass pipette, and then the sperm, you can just see the sperm going down here, and it goes into the egg cell. It's amazing. You can stick a needle into an egg and it survives. Like many good things, ICSI was developed purely by accident. They were trying to put the glass pipette inside the eggshell, but outside the egg. But they slipped and it went into the egg and the egg fertilized. So they thought, well, we'll try that again. And it worked again. And that's how ICSI was born. And it radically changed the number of people we could treat with infertility. Prior to ICSI, we could only treat about 13% of male factor infertility. Now we can treat 87% of male factor infertility with just the same success rates as you would expect with IVF. Next slide, please. Now, originally, we used to put embryos back on day 2 or day 3 when there were between 4 to 8 cells. However, in the early 2000s, we developed our culture techniques such that we could grow them to the blastocyst stage. Why is this important? Because instead of putting multiple embryos back, which gives you the risk of twins and lots of complications, we wanted to select the best embryo to go back, which improves your chance of getting pregnant, but takes away the dangers and risks of a twin pregnancy. So we learned what an embryo needs to reach the blastocyst stage, and we now routinely culture the embryos in our special incubators in undisturbed culture until they reach the blastocyst stage, which is day 5. So they go from the first day when we check to see it's fertilized, where it divides into one cell, up to a blastocyst stage at which it's got between 120 to 160 cells, an outer bit that's going to form the afterbirth and an inner bit that's going to form the baby. And it's at this stage we select the best embryo to go back. Next slide, please. Now, most women having a fresh embryo will have a fresh embryo transfer of a single embryo. However, there are circumstances where we may freeze embryos. For example, you may produce 4 or 5 good quality embryos, what we term usable embryos, good graded blastocysts, which we believe will survive the freeze-thaw process and provide you with a really good chance of a baby in the future. So we would freeze those spare embryos. Occasionally, you might produce too many eggs, and therefore you're at risk of developing probably the most serious side effect of IVF, ovarian hyperstimulation syndrome. And so if you produce more than 20 eggs, then we'll still go ahead and collect the eggs, we'll still fertilize and make the embryos, but we won't do a fresh transfer. We'll freeze the embryos. And around 6 weeks later, we'll put one of the embryos back through in a hormone replacement cycle. But don't worry, the chance of having a baby is just as good with the fresh and frozen transfers. And changes in the freezing techniques means that around 98.5% of embryos survive that freeze-thaw process. The other time we might freeze embryos is when we do genetic testing while we're waiting for the biopsy results, and I'll come on to that in a minute. Next slide, please. So the embryo transfer, and here you can see on the left a picture of a blastocyst embryo with multiple cells, and it's just beginning to hatch at around about 2 o'clock there. So if you look at the next slide, you can see that the transfer itself, we use a very pliable small catheter. You do need a speculum examination, but this time it's normally done without sedation. For those that are worried about and have trouble with smear tests, we can give sedation, but in general, the majority of transfers are performed without sedation. You do need a full bladder though, so it is a bit uncomfortable having a speculum with a full bladder, and we need the full bladder to see where we're putting the embryos to make sure they go back in the right place. And we put one embryo back at a time. Now, the embryo transfer takes 10 to 15 minutes to do, so it's quite a quick, simple procedure. You don't need to rest in bed as soon as you've had an embryo transfer. The embryo's not going to fall out. But I wouldn't go and play an active game of squash or anything like that. You might have a nice easy day for the next 2 to 3 days. Next slide, please. So once you've had the embryo go back, you've got a 2-week wait. It's a nerve-wracking rate while you're waiting to know whether the treatment has worked. During that time, we give you some additional progesterone to help support a potential early pregnancy. Next slide, please. Normally, we do a home pregnancy test about 13 days after the embryo transfer. If the test is positive, we organise for you to have an ultrasound scan to confirm the pregnancy at the equivalent of 7 weeks gestation. So that's 5 weeks after the embryo transfer. And we do it then because at that stage, we should be able to see an intrauterine gestation sac, we should be able to see a fetus, and we should be able to see the fetal heart. So that's why we do it at that time. And we should be able to measure the length of the fetus to make sure it's an appropriate size for the dates. Unfortunately, if the test is negative, we'll then make an appointment for you to come back and see one of my colleagues or myself in the clinic, where we'll guide you through the next steps. Next slide, please. What can we do to improve your chances of success? Well, IVF per se has improved tremendously the success rates since we first started, and certainly since I first started doing IVF some 40 years ago. But there are a couple of things that we've got which we use a lot at Care, which we'd encourage you to use. Next slide, please. One of these has won 2 or 3 awards, the Royal College of Pathologists in London. And this is an artificial intelligence program which we use, which gives your embryos a score out of 10. And it gives you a chance of a success. So, for example, if you're under 30 and you have a 10 out of 10 embryo, the chance of that implanting would be somewhere between 55 to 65%. Whereas if it was a 5, it might only be a 40% chance. So using this technology, we can grade the embryos and put back the best one first so that the time to pregnancy is reduced. Next slide, please. One of the main reasons for IVF not working as you get older and the decline in fertility as you get older is an abnormality in the embryo, and that's caused as the eggs age. And you can test for that abnormality by doing pre-implantation genetic testing, where you take a few cells from the portion of the embryo that's going to form the afterbirth. So you don't touch the inner cell mass, which is going to form the baby. And you genetically analyze those tests for the chromosomes. Most of us will have 46 chromosomes, 22 pairs, and then a pair of sex chromosomes. In boys, it's an XY. In girls, it's an XX. And we can test for that in the embryos to make sure they're normal. If you are at the age of 37, approximately 45% of your really good quality embryos may be chromosomally abnormal. By the time you're 40, 66% are abnormal. By the time you're 42, 78% are abnormal. And by the time you're 44, 90% are abnormal. Therefore, doing PGTA, particularly over the age of 37, allows us to select normal embryos to go back. And the difference is enormous. So, for example, at 40, the routine chance of getting pregnant with untested embryos would be about 25%. But if we test your embryos and we put a normal embryo back, the chance of having a viable clinical pregnancy is between 60 to 70%. So it makes a huge difference. Now, it can't change the basic genetics in your embryo, but it selects the right embryo to go back. So it reduces the time to pregnancy and reduces the risk of miscarriage. Next slide, please. Of course, there are other considerations, and not everybody that presents to our fertility clinics needs IVF treatment. So I'll just briefly describe some of the other treatments we have. Intrauterine insemination. This is where we prepare the sperm, we wash it as we would do for IVF, and then we insert it with a special catheter through the neck of the womb at the time a woman is ovulating. Why do we use that? Well, some heterosexual couples need to use it if they're unable to have sex. It could be that your husband works on the oil rigs and he's not going to be around when you're ovulating. So we can freeze some sperm and then we can do the inseminations using that frozen sperm. So you've got a chance of getting pregnant while he's away. It could be that for various reasons, it could be because the man can't maintain an erection and can't ejaculate, or it could be that the woman is unable to have penetrative intercourse. In those cases, we can do IUI. Sometimes we do that under sedation if there's a problem with being able to have sex. Of course, we use IUI in a lot of same-sex couples who present with donor sperm. Next slide, please. So for same-sex couples, next slide, we can use donor sperm, we can use donor eggs or embryos, depending on your relationship. So the majority of same-sex women present earlier than the average age of women coming through in heterosexual relationships because they know they're going to have a problem at an earlier stage in their relationship. And in those cases, we can use donor sperm with intrauterine insemination. In Leeds, our NHS clinic, NHS services, the ICBs, fund up to 6 cycles of donor insemination on your natural cycle. However, if that doesn't work or you present later, we might opt to go along IVF using donor sperm, to use that 1 amp of sperm on maybe 10 to 12 eggs rather than just the one, to try and find the best one to go back. In male couples who want to have a child, we can use donor eggs. If your ovaries have stopped working prematurely, or you've met late in life and your ovaries are not working as effectively, we can use donor eggs to help you conceive. If there's problems on both sides, we also have some donor embryos that you can use too. So we have our own dedicated egg, sperm, and embryo bank. And we can also use sperm banks from overseas as well, as long as they comply with the HFEA, our regulators' regulations. Next slide, please. Some same-sex female couples like to use shared motherhood, so that it's sometimes known as reciprocal IVF. So it's designed so that both you and your partner can share your family building experience. So one of you would donate your eggs to use in the IVF treatment process as the biological mother, and then your partner carries your baby by having the embryo transfer, and you would be the gestational or birth mother. Next slide, please. So in same-sex male couples, we need to use surrogacy. So we used a surrogate to carry the pregnancy. And this could either be through straight surrogacy, where we use the surrogate who provides the donor egg, and one of the male same-sex couples provides the sperm, or we can do host surrogacy, where you use a donor egg and one of the partner's sperm, create embryos, and then that goes back into an independent surrogate with an embryo transfer. And we can use that in same-sex male couples and individuals assigned male at birth. Next slide, please. So why would you choose Care Fertility for your fertility journey. Next slide. I'd like to think that we support you every step of the way. We have the initial patient inquiry team who will help you, provide you with some basic information and talk you through and see whether you'd like to make an appointment with one of our specialists. We have a huge resource of information at Care on our resource hub, patient information, which is really helpful to help make you understand the issues that you face. We have some fantastic patient services. So once you've actually seen one of our doctors, you've got an idea of what's going on. They can direct you, provide you with all the information that you need that our doctor has suggested, the tests that he's suggested, he or she's suggested. And they can make your follow-up appointments, make details for your treatment. They can send you cost estimates if you're paying for your treatment. We have a dedicated counselling team. Some treatments, using donor gametes, for example, you need by law to have counselling, implications counselling. But in others, counselling is there to support you on this because some people find this journey really hard. We also have lots of social media, and we have a brilliant app called Salve, which we use to send you lots of patient information, appointments, reminders of when you have to take your medications. So it's a really good way of communication and getting quick answers to some of those questions which may arise during your treatment process. Next slide, please. We have clinics throughout the country. So we have care clinics across the UK with world-leading expertise, both nursing, medical and laboratory, 16 clinics across the UK and in Ireland. Next slide. But of course, we also have above average excellent success rates, and the cumulative live birth rate per egg collection under 38 is over 50%, which is much higher than you'll find on average published in the HFEA data. So we've got excellent success rates too. Next slide, please. We also have a range of payment programs. We work with a specialist IVF finance partner, Access Fertility, to provide our clients with IVF patient programs. We've got IVF payment programs that can offer a refund cycle, multi-cycle treatments, or with IVF needing donor eggs, we've got egg refund program. So why might you use one of these packages? The multi-cycle packages at a fixed discounted price, some up to 100% refund if the treatment doesn't work. And there are interest-free credit options available. It helps spread the cost. It helps make it more cost-effective to get your successful treatment. Next slide, please. Getting started on that journey, you would, we have bundled things together so you can have all your tests, the immediate tests done. Now, you might need some more specialized tests, but these are the main tests that we would want for you, you to have before you have a 45-minute consultation with one of our fertility experts. And we bundle that together to give it a total cost of £549. And at Care, we're committed to this inclusive fertility care. And this offer is open to all couples and individuals that want to start a fertility journey. Next slide, please. So we promise at Care to do everything we can in our power to make your dream of having a family come true. We will try and ensure you feel seen, heard and supported every step of that fertility journey along the way. Thank you. Right. Have you any questions?
Hi, Tony. Thanks for that. That was really helpful. I've got lots of great questions here this evening. So let's get started here. First one, if my partner's semen analysis shows 100% abnormal morphology due to pyriform heads, would ICSI help us, or should we be looking at donor sperm?
I think this is a very technical one for the embryology team. Generally, a normal sperm is needed to fertilize an eggs. I think the chances of success under these circumstances would be very low. But I think it's one of those that I would refer to as a doctor, even having worked in this for 45 years, so 40 years, I would actually ask one of our senior embryology team about what should be done in these circumstances. I think that you do need to have normal sperm to give you a good chance of a successful pregnancy.
Brilliant, thank you. What is the best ovulation kit, and when do you start testing for ovulation?
Well, it depends on the length of your menstrual cycle. You tend to, the second half of the menstrual cycle is fairly fixed. It's 12 to 14 days. The first part of the menstrual cycle is the bit that varies. So it depends. So if you've got a 28-day cycle, you're going to ovulate around about day 14. So you might start doing testing from around about days 9 to 10. Bear in mind, the urine is what you're looking for is to pick up your LH surge, which the LH surge makes you ovulate. Now, when we're measuring it in the urine, we're measuring it 24 hours after the surge has happened. And so you will literally ovulate around about, 16 hours after it's happened. So you'll ovulate around 24 hours later. So it's important that you perform that test in enough time just to make sure that you don't miss it starting. Because even though we think we've got 28 regular days, sometimes they come a little early. So if you've got a cycle that is a bit more irregular, then you're going to need to have a broader number of days in which you test. If it's pretty regular, but it's say 35 days, then if you have a 35-day cycle, you're probably going to ovulate around about day 21. So you might start testing from around about day 15. So it depends on your cycle length. If you've got shorter cycles, maybe 25 days, then you're probably going to ovulate around day 11. So you might want to start doing the test between day 7 and 8.
Thank you. Another great question here. Have you had people over the age of 45 use their own eggs and have successful IVF? And if not, why not?
It's a great question. There are successful pregnancies over the age of 45. Between 45 and 46, the pregnancy rate using your own eggs is 1.9%. In other words, 2 out of 100 ladies.
Wow.
So it's very low. Over 45, so if you're 46, that declines to 0.5%. In other words, 1 in 200. So occasionally someone will say to me, I've got to know, I've got to try. I know the chances are really, really poor, but I just have to give it a try. And in those circumstances, as long as they're aware and they've been counseled about their chances and they want to do it, we'll do it. We will not, as a matter of routine, do IVF other than under exceptional circumstances over the age of 45. So if you're 46, we think that the balance, the risk of doing the procedure is greater than the chance of success. In other words, doing harm is greater than the chance of doing good. And as a doctor, we shouldn't advocate that.
Absolutely. That makes sense. Thank you. And just sort of following on regarding egg quality, is it worth taking coenzyme Q10 or anything else to improve the quality of eggs?
Okay. So I think that's a really good question. I think that diet is really important. You need lots of antioxidants. And I think diet rich in antioxidants is something a typical Mediterranean style diet. Olive oil, virgin olive oil in your cooking, lots of fresh salads, chicken providing zinc, or omega-3 rich fish like salmon. A nice balanced diet like that is useful. There is evidence that coenzyme Q10 may be good. And there was a paper published in the New England Journal of Medicine, it's a bit like the English Lancet. It's the British Lancet. It's a really good, or thought of as a really good journal. And there was a paper in there where they looked at a randomized trial using coenzyme Q10 at a dose of 600 milligrams a day. And it showed that the quality of the embryos produced if you took coenzyme Q10 compared to taking no coenzyme Q10 was much better. So I certainly recommend taking it. Coenzyme Q10 works by helping electrons across the mitochondrial membrane. And that helps make more energy. The mitochondria are the parts of the cell that make more energy. And therefore, if your eggs have more energy, they're more likely to be normal.
Amazing. Well, thank you. Another question here. What happens if there are no follicles present when I have my internal ultrasound scan?
So if you have no follicles, you've got, if they're not developing at all, it's likely that you'll have irregular periods. If you've got periods, they're likely to be at least one follicle present. Tests that you would do under those circumstances include doing an AMH test and an FSH test. The AMH, if it's less than 0.5, and the FSH, if it's above 30, would indicate that you may have ovarian failure. Under those circumstances, the best treatment for you is going to be egg donation.
Thank you. And just on FSH, question here, is 5.6 a good FSH for a 42-year-old?
It is. It's in the normal range.
Excellent. They'll be happy with that one. Here's another great question. How can endometriosis impact how easy or safe an egg retrieval is?
Okay. It is a good question. And every patient who has endometriosis, we look at on an individual basis to decide whether they should have their endometriosis treated before they start their fertility journey. Sometimes endometriosis, when you bleed in your tummy, which is what happens when you have a period with endometriosis, because the endometriotic tissue is like menstrual tissue, and it bleeds when you bleed every month. And blood is a great glue, and it can stick things together. So your ovary might become stuck at the top of your womb, and therefore it makes access difficult. Now, sometimes we can overcome that because the vagina is quite stretchy and we can reach it, but sometimes it can't, and sometimes you might need surgery to release it. You might have a cyst in the ovary caused by endometriosis, and we have to balance up how risky that is. Should we drain that cyst before we perform IVF, or should we leave it alone? The eggs will form generally around the surface of the cyst, and we may be able to get most, but not all the eggs. We don't really want to stick a needle into the ovarian cyst because the cyst contains altered blood. Altered blood is like a really rich culture medium for bugs. And so you might get an infection. So if we accidentally puncture a cyst, an endometriotic cyst during the course of an egg collection, we will give you some prophylactic antibiotics. So Each individual we look at carefully and make a plan with the patient prior to starting their treatment, whether to have surgery, not to have surgery. Now, overall, if you looked at the success rates of patients having endometriosis or don't have endometriosis, the overall results seem to be very similar. However, if you've got really bad endometriosis, which has damaged your ovarian function, then the success rates would be lower because you haven't got the same ovarian reserve.
Amazing, thank you. Another question here. Can you use IUI if you have polycystic ovaries and irregular ovulation?
Well, you can do, but you're probably better just having ovulation induction to make you ovulate on a regular basis and then having sex naturally, because there's just the same chance of getting pregnant.
Brilliant, thank you. We've got a PGTA question here. So does PGTA testing cause stress on the embryo?
Okay, it is a good question. That over 95% of embryos tested do survive the process intact without any problems. It is a stress. It's not 100% survival, but I still feel that it is such a valuable test and that it does give a lot of information which would help you on the time to pregnancy. For example, let's say you're 39 and you've got a good ovarian reserve, and let's say you make 8 normal looking embryos suitable for freezing. You put one back, it doesn't work. It may take 2 to 3 months for you to put the other one back, doesn't work. 2 to 3 months to put the other one back, it doesn't work. You can see you could put back 4 or 5 embryos, taking a whole year or more before you find the one that actually is normal and will give you a baby. Now, if you were to test those, and if you were 39, 50, nearly 60% would be abnormal. So that would mean you'd have, 3 out of 8 that were normal. And then you put one of those back, it would give you a 60 to 70% chance of a pregnancy. And each one of those would do. So the chance of you getting pregnant the time it takes would be much reduced. And the risk of miscarriage would be much reduced. So I do think that no test is 100% safe, but it is over 95% safe for the embryo.
Potentially save a lot of heartache and a lot of money,
Yes.
hopefully. Excellent, thank you. Can you have IUI if your partner has a low sperm movement and low morphology?
No, it's not going to work. The egg isn't going to fertilize.
Cool, thank you. That's a good quick answer.
Yeah.
Let's have a little look here. I have a history of ectopic pregnancies and have had 1 tube removed. Will IVF decrease my chance of an ectopic pregnancy again?
It will do, but there is an increased chance of an ectopic in the tube, even with IVF, compared to so about 3% of all IVF pregnancies are ectopic, because the embryo is put in a big catheter in a little droplet of fluid. But once it goes back into the uterine cavity, the little cilia on the hairs of the endometrial cells waft the embryo around, and it may be wafted up into the tube. So it can still result in ectopic, although the chances are lower.
Thank you. And I think we've got time for one last question here. I can never say this properly, adenomyosis. Sorry, that's terrible pronunciation. Could this affect implantation with IVF?
Okay, it is a very good question. It's adenomyosis.
Thank you.
Adenomyosis is endometriosis, but in the wall of the womb.
Okay.
So you get glands of endometrial tissue forming little cystic spaces in the wall of the womb. It is commonly associated with painful, heavy periods, and it can make the uterus quite bulky. There is really little evidence that any specific pre-treatment of adenomyosis, like suppressing ovarian function for 3 months beforehand to try and suppress the adenomyosis, will make a difference to the outcome of IVF treatment. It may have an impact on your implantation, but it shouldn't stop you going ahead and having IVF treatment.
Amazing. Thank you. I'll just wrap it up to let everyone know if we didn't get to your question this evening, please feel free to email the inquiries team at carefertility.com, or you can give us a call on 0800 564 2270. The team is available Monday to Friday, 8 a.m. till 6 p.m. and Saturdays and bank holidays, 8 a.m. till 4 p.m. I will let Dr. Rutherford wind up for this evening. Thank you.
Okay. Goodbye. I hope it's been helpful. Do come and see us in one of our clinics, and I'm sure they'll be able to help. Thank you.